Transplantation is not a cure. Instead, it is replacing a life-threatening condition with a chronic condition. No one knows what the lifespan of a transplanted heart will ever be. What we do know is that in most circumstances, a transplant can help a critically ill child lead a relatively normal life. Before your child is placed on a transplant waiting list, the transplant team at Children's will carefully evaluate what is best for your child. This will consist of laboratory tests, such as blood and urine tests, a psychosocial evaluation, and a cardiac catheterization.
The evaluation process for pediatric transplantation is really two different processes. There's the child who is acutely ill in the intensive care unit, and then there's a child who may need a transplant but is less ill and is likely an outpatient. So they go in two different lines. The child who is acutely ill in the intensive care unit, a lot of quick decisions have to be made, and in a very timely manner in order that transplantation can occur. The child is evaluated from a medical point of view to assure ourselves that there is no medical or surgical therapy available that would help the child, and then the family is also evaluated to make sure that this transplantation is something they want to deal with and can cope with.
Once your child is accepted for a transplant, he will be put on the waiting list for a heart. UNOS, the United Network for Organ Sharing, is the national agency that oversees organ allocation and transplantation. This agency maintains a national computerized transplant waiting list. Comprehensive range of factors like geography, patient condition, patient size, and blood type are considered when matching organs with patients. The list of children awaiting transplant is prioritized by status. Status 1A, patients on life support or high-dose inotropic medications. Medications administered intravenously to make the heart pump stronger. Status 1B, patients on low-dose inotropic medications. Patients less than 6 months old, and patients who are less than the 5th percentile in height or weight for their age. Status 2, patients who are in need of a heart transplant but who do not meet the criteria for Status 1A and 1B. There are many emotional and physical challenges you and your child will face after a transplant. One of the risks of transplantation is rejection, when the body recognizes that the new heart is foreign and tries to reject it.
Once a child has received a heart transplant, there is a lifelong commitment of follow-up appointments, procedures, and lab work that has to follow in order to create the best possible environment for that child to do well.
And if there is rejection, it can be treated with medication.
Rejection is a lifelong threat. No matter how well you've done for however long a period of time, that threat is always there. When rejection occurs, it's often treated and treated successfully, but sometimes it is not. There are various forms of rejection. The most common one is what we call acute cellular rejection, where the white cells in your body attack the heart. We have good medical therapy to prevent that and to treat that if it occurs. There are other types of rejection, antibody-mediated rejection, and types of coronary artery disease, which some people think of as rejection, which we do not have good therapies for. And the likelihood of the coronary artery disease occurring with time increases as you have your heart.
We can't emphasize enough how important it is to know going into a heart transplant that there's a commitment of time every day in making sure that children are taking their medications and following up with the transplant center.
The transplant puts us in a situation where we have to deal with this as a lifelong issue. Managing her heart health is just something that becomes part of our life. For us, we've been so far out that it has kind of just become woven into what is the fabric of our day-to-day living.